Welcome to PTY 103, part 2 of the video series that you've been looking at. The purpose of this video is really to, when we look at the objectives, is look at this bottom objective, the structure to function. This is what this video is all about, structure and function. I'm just going to start off talking about the complex itself, and then we're going to zoom in onto the glen-numeral joint, at which point colleagues are going to jump in and we'll mix it up, and you'll hear from both myself, Chris and Rob. So within the complex we've got three main bony structures. We've got the clavicles, obviously left and right. We've got the scapula, which is a very unusual shape and is an irregular bone. When we look at the structure of it, and you realise that there's fosses, there's dips, there's crests, there's spines, there's protuberances, everything is there for a purpose. So remember, when you're talking about structure and function, that everything that you see is something to write about. And of course we've got the humerus itself, which is a long bone. So we're going to dive into the glen-numeral joint. It's a ball and socket joint, it's triaxial, multiplanal. That gives you a lot to talk about. So I'm going to hand over to Chris. Chris is going to jump in with a bit of Rob, and we're going to sort of start exploring its function.
Okay, thanks Ivan. So we're going to look at the glen-numeral joint specifically, but just to orientate you a little bit, we're going to talk about the other joints involved within the shoulder complex. Ivan's kindly discussed the bones, which are the clavicle, the scapula and the humerus. It's recommended that you read up on these bones and you understand the the parts of the bones, the projections, the fosses, etc. Okay, so the joints are, we have the glen-numeral joints discussed, but first of all, here's the arm. How does the arm attach to the axial skeleton? Well, it's through this joint here, which is the sternoclavicular joint. So it's a synovial joint. Okay, so then it's the sternum to the clavicle. We have the clavicle that comes up here, and then we have, this is a part of the scapula called the acromion. And this is another joint here. This is the second joint of the shoulder complex, the acromioclavicular joint. Okay, the joint between the acromion and the clavicular. This too is a gliding or plane joint and is a synovial joint also. And then we have the glen-numeral joint that we're going to go into in more discussion. This is a ball and socket joint, and we'll talk about that. We also have a fourth articulation, which is not a true joint, it's a pseudo joint, and it's the articulation between the scapula. So I'll just turn this around, Rob, is that alright? So it's the articulation between the scapula and the rib cage here, and that's called the scapulothoracic junction. Okay. Let's talk about the glen-numeral joint. As I've mentioned, it's a ball and socket joint. Okay, so it is the ball and it's the socket in there. Okay, so the ball fits into the socket. Unlike the hip, which is also a ball and socket joint, which is a large ball and quite a deep socket, the shoulder here has a large ball and quite a small socket. So it's been likened to a golf ball on a tee, or a seal with a ball on its nose, balancing a ball on its nose. It's inherently unstable and therefore relies on other structures to provide the stability.
So as Chris mentioned, we've got a small socket, which would be likened to a golf tee, and a large ball, which would be likened to a golf ball. That means it's a small surface area of support for a large surface area of the humeral head. That makes the joint inherently unstable. So it needs some other structures around it to make it stable. You've got some of the shape of the joint which provides some stability through contact. Then you have a cartilaginous ring known as the labrum. That increases suction cup stability. You've got your capsule, which is a wraparound bit of tissue that creates stability of the whole joint. And then, as Ivan alluded to, we've got the rotator cuff, which live in these fossa of the scapula, which wrap around and attach into the greater tubercle of the humerus. Then you've got the long head of biceps, which creates anterior stability, and there's two portions of the biceps, the long head and short head. The short head attaching to the coracoid process, and the long head attaching to the supraglenoid rim. When you're moving the shoulder, If the scapula was stable and didn't move at all, because of the bony anatomy of the shoulder, it would only go so far depending on the shape of your individual shoulder. So in order to get elevation of the shoulder, there needs to be some combined scapular motion at the same time. And I can talk to you a little bit about that dynamically on the whiteboard. But essentially, things move in partnership. You've got your prime movers and your stabilizers. So as your shoulder's moving, it has to create constant tension to create this dynamic stability, holding that ball and socket joint into the socket, and create tension enough to move the scapula and elevate this very, very heavy object when it's out in full.
Can I just ask you then, Rob, so it sounds like we've got this inherently unstable mechanism, this big ball on this little cup here. I mean, the primary function is obviously to move the arm, this heavy object, and to enable you to do things with the arm. So it needs to hold the arm out in the extended flex position. So what you're saying is that there's the labrum, which kind of goes round the glenoid, and that provides further surface area, is that correct?
That's correct. So the labrum would go in this orientation, not this orientation. So it creates a larger surface area of that golf tee to create more contact with the joint surface and create a suction in tandem with the capsule.
And I was reading from Bucknell and Kahn, and in their text they say that actually the labrum increases sort of superiorly and inferiorly the surface area by about 75%, and again anteriorly and posteriorly they reckon it's about 50%.
Yeah.
So that's a significant size. And you also mentioned because it's that sort of fibrous tissue, it provides a sort of suction onto the large head as well. And I'm really interested in the role of the sort of long-headed biceps that you said came into the sort of supraglenoid. That merges with the labrum?
Yeah, so it would fuse with the labrum, which is why when you get an injury of the long-headed biceps at its insertional point, sometimes it can peel a lip of that labrum away, which breaches the suction cup seal, therefore creates some level of instability compared to a pristine labrum.
Okay, so essentially, so those are kind of the inert structures of doing that. Obviously, I understand there's ligaments as well that are going from the to the humerus, the glenohumeral ligaments. And again, sort of I advise everybody to go up and read on about those glenohumeral ligaments because they are a really important static stabilizers. But I was really interested in the sort of rotator cuff. So I understand that you were talking about that, and the rotator cuff again, that works with the sort of the deltoid that sits over here, doesn't it? Because we've got the anterior medial and posterior deltoid, and the deltoid does movements such as sort of abduction, sort of flexion and extension.
Yeah, and that would be, if you were to think about the orientation of those fibers, you've got this teardrop shaped object called the deltoid. It's split into 3 sections.
Yeah.
You'll never isolate one of those sections, much like you'll never isolate the cuff into one muscle. It works in partnership. But if something is orientated slightly in front of the midline, it has to have a combined abduction and flexion movement. If something is orientated behind the midline, it has to have a combined abduction and extension movement.
Sure.
So it's combination of movements rather than pure linear isolated movements.
Yeah, so the combines are sort of realistically what's going on within things. So, and then the cuff itself. So if the deltoid's moving this, what's to stop it? Because the deltoid obviously it's a large muscle. It's one of the strongest muscles in the upper limb. If it was to pull, I would imagine it would sort of bring the head of the humerus up quite high. So does the rotator cuff do something else to support that?
So
to stop the head of the humerus riding up?
Theoretically, yes. If you think of this acromion, which is different shapes in different people, it acts as a little bit of a cam or a speed bump. So as the humeral head hits it, it would have to climb over it to get over. So if you just had pure deltoid power lifting that up, you would lose stability of the shoulder. So theoretically, to maintain stability of the shoulder, you've got 2 actions here. You've got an inert action, which is the slippery surface of the chondral cartilage mixed together with the lubricant of the synovial fluid. That allows a slippery glide within the ball and
joint,
socket. And you need something to depress the ball and socket. So you need that cuff, which hugs, but acts to give enough depression force to allow the slippery stuff to do its job.
So they almost acting as guy ropes of a tent, sort of pinning it down to keep the tent in one position.
All directions.
In all directions.
Yeah.
So they're acting as guy ropes to almost, with the glenoid labrum and the long head of biceps and the ligaments, to kind of keep the head of that ball, head of the golf ball almost centered on the tee.
Yeah, so if you were to think about a wheel spin,
Yeah.
you've got a lot of torque and lower friction. So if you had lower friction, it would spin. If you had higher friction, it would climb. So it has to spin within itself. So that's part one of it. Part two of it is the scapula has to move with.
So we're gonna show that on the board just now.
Absolutely.
Okay.
So what I've got on the board already is just a few thoracic vertebrae and sort of representation of the rib cage on the left hand side. So we're looking at somebody from behind. Okay. And in order to allow that shoulder to move, you need movement of both the scapula and the glen-numeral joint. So if we think about it in simple terms, this would be your scapula. That's that plate-shaped bone that Ivan was talking about, with all these lovely lumps and bumps and fossa, which I'm not going to draw. Then you've got your ball of your ball and socket joint and your humerus. So in order to achieve the action of abduction, without anything else helping, as Chris was saying, it may get stuck due to the shape of the anatomy. So what you would require is the deltoid helping. You've got the trapezius muscles which attach to the scapula. The rhomboids. Behind what you can't see is another part of your cuff and your serratus muscles which attach it to the rib cage. And then you need some sort of stabilisation from the teres minor and the latissimus dorsi. So if you think about them attachments, you've got something that's pulling in this direction, but because it's attached at the far point, it also creates a degree of elevation. So diagonal motion and elevation combined, therefore, create a rotation movement. And the same can be said for what's happening inside the glen-numeral joint. So in order to achieve elevation of the shoulder, you need the scapula to come up and rotate at the same time that the ball rotates within the socket. So in the scenario when we're examining somebody, we would always fall back on our minimum standards to make sure that we've washed our hands, make sure that we've introduced ourselves to the individual and gained consent from that person that they're happy for us to examine them and for us to place our hands on them. For the purposes of today, we've already achieved that by speaking to Chris beforehand.
I'm more than happy.
So when you're looking at an individual, it differs to when you're looking at a skeleton or an image, because there's tissue on top, and that would give you you would lose some of the visualization that you would have just from the skeleton. So the movements we're going to do today would be a scaption-based abduction, where it's not purely out to the side, it's slightly in front. Because of the angulation of the scapula, it's a much more comfortable movement to get it out to the side by bringing it in front of the midline. So as Chris was to lift his shoulder up and I were to block his scapular motion, he could only get so high. If I was to give him or allow him more scapular motion, by lifting that scapula up and rotating it, he's now achieved full elevation of his shoulder. So if we come back down, so if you were to look at that by me framing the scapula, so this is the top border of the scapula, and this is the inner border of the scapula, and it would be more angled that way. So as Chris was lifting up, his scapula is coming round in that direction, and he comes back down. So if you look at the bottom angle, the inferior angle of the scapula, it rotates this direction, comes across the body and round the front of his rib cage almost, as the scapula elevates. So once more, Chris. So rotation and elevation. Now, for example, if you were to look at any joint, you would want to look above and below, or to the left and to the right in this case, and we would want to make sure that the thoracic spine is not ignored in this case. So if we were to give Chris a kyphosis, and asking him to stoop, and he was to then try and flex his shoulder above his head, it would get stuck. So scapular rotation is not being blocked here by my hands, but it's being blocked by the thoracic spine. So if we were to give him thoracic extension, we can achieve much more movement. Now what you can't see is that's because it's coupled with the clavicle. Okay, so as the acromion meets the clavicle, as the scapula meets the clavicle at the acromion, it does this. And you can only achieve that by having full thoracic extension.
So thanks to Rob and Chris, they've talked about how the anatomy works to provide functional movement. The integrated glen-numeral, scapulothoracic and clavicular motion is key to how the shoulder complex works. The glen-numeral joint itself is the one that we're largely concerned about when we talk about shoulder movement, and it's very important that you understand how those muscles and how those bony landmarks and how the associated structures above and below work together in harmony to provide the functional movement. You'll read a lot about the shoulder dyskinesis, shoulder movement. There are lots of people out there who are published and have theories. We'd encourage you to go to that wider reading to gain a deeper understanding. Shoulder function is significantly dependent on normal biomechanics. So when any part of the system or any component of this wider complex, this wider system fails, it leads to dysfunction. So to summarise, balance is the key to life. Thank you very much for watching.